Hey, Venky, how are you?
Thanks, Alan. So I just want to give you an update. All the patients we did yesterday, all 3 cases, are ready on the launch pad to go home today. So they've done well. And that's the beauty of doing endovascular. They're quick, it's easier, less invasive, and patients do really well. So we are moving now from the toes to the belly. Today we're going to go up to the head and the chest. So the whole session is about TCAR and carotid stenting, and of course, the other modalities that are now coming up too. So what I would like for this session to discuss is 1, TCAR, the procedure itself, which I think Cassie presented really well. Also, what are the limitations of TCAR? Like he said, the runway, the extensive calcium, and how we can overcome those. For example, Dr. Arco is supposed to give a talk about shockwave for really calcific lesions, and we can discuss that since he's sick, apparently. I'm sure he's playing golf somewhere. That's one part. And the second, of course, is the controversial, I wouldn't say controversial, but the acceptance of carotid artery transfemoral stenting and how that's going to play out not only in the community, but also is that a risk in terms of the TCAR numbers, who's doing it, how do you follow those patients, and what is the status of carotid interventions. And the last portion we need to discuss is what else is in the pipeline in terms of carotid interventions. Are there any new devices, new ways of flow reversal, and things like that? So that's the whole build-up for this session. So let me present the case we have today. This is a really interesting case, actually. It's a 78-year-old male with multiple comorbid conditions, as they all are. He actually got admitted through the emergency room with right-sided weakness and expressive aphasia. Go to the next one. He was actually seen by neurology because it's a stroke, and a CTA head and neck was done, showed severe left ICA stenosis. MRI of the brain showed acute embolic infarcts in the left MCA distribution. So obviously, the interventionalist said that, yes, he needs to be intervened upon. He was relatively stable, neurologically, no major neurological deficits, and so they took him to the interventional suite. And one thing you can see in his CAT scan, he's got like a type 3 arch, if you can see on the left side here. Okay, go to the next one. So they performed cerebral angiogram, carotid stenting was attempted. They were unable to gain access into the left carotid from both the right radial and the femoral axis sites. And ultimately, the intervention was aborted. They decided to put the patient on dual antiplatelet therapy and send him home and then bring him back later as and when needed, and if needed also. So he was placed on aspirin and Plavix, and he was then discharged. These are the images done in the neuro. The patient then develops a right common femoral pseudoaneurysm that required 2 thrombin injections. His radial was luckily doing well. So then he goes home, he's on aspirin and Plavix. Go to the next one. And then he has recurrent TIAs 2 weeks after discharge. This time we saw him in the office. He was referred to us in the office for possibility of NDOT or maybe even a TCAR. He has been compliant with aspirin and Plavix, but I think this is another thing recently we've noticed on a couple of patients, the non-responders to Plavix. And now, at least in our hospital, this test is readily available. Before, it was a little difficult to get this. And we've seen 2-3 patients as non-responders to Plavix, and one of them actually, after TCAR, had a small TIA, and that's when we changed them to Brilinta. So this patient has now been loaded and started on Brilinta and aspirin, and now we felt that he was a good candidate for a TCAR procedure. So any comments on this history?
You want to run that video, the animation?
No, just go ahead. So what do you think, Alan, about the history of the patient and what is the appropriateness of what we do? Should we do an NDOT? Is TCAR the best procedure? So based on, you will see, you've got to do a lot of homework when you do these because you get only one chance at this. So you need to know the runway, you need to know the diameters, you need to know the angulations, you need to know the cerebral perfusion. And I thought this was the ideal case for TCAR and not transfemoral, and failed radial. So we brought him in, and let's talk a little bit about the TCAR procedure. I think this procedure does not take, as Cassie said, 25 to 35 minutes. It's quick, it's easy, it's very repetitive. The steps are almost like consolidated so well that you really don't even have to ask for any instruments or procedures. It is so repetitive that you can really finish this procedure very quickly. Exposure takes 3 to 4 minutes. And then, of course, you puncture the carotid, puncture the vein, so you should be ready. So that's what we've done so far. If you come to the neck, you see it's a small incision just above the clavicle, about 3 to 4 centimeters. You isolate the carotid. I still tend to use a Roumel. Some people use vessel loops. Then we go into the groin, generally on the opposite side or ipsy side, depending how comfortable you are, and then you create this reversal of flow technique. You puncture the carotid with a micropuncture needle and introduce the microsheath. And I think the whole operation is based on getting that en route carotid sheath into the carotid without any major problems of dissection, back wall, and getting a wire there. Once that sheath is in place, I think this procedure is almost too easy, to be very honest. So the next thing you have to do is known as like a TCAR minute, where you make sure that the blood pressure is higher than 150. You make sure ACT is 250. If you use transcranial Doppler, that is really, really good. And I agree with Alan, that's something that needs to be incorporated into a lot of the practices. We do cerebral oximetry. We keep the pressure at 170 if you look at the hemodynamics. And then once all of that is said and the TCAR minute is ready, you keep your balloon ready and more or less wait for the stents which you're going to use. But all of this is predetermined. So now everything seems to be good, and I'm going to clamp the common carotid so as to establish reversal of flow. Okay, the common is clamped. We then check for reversal of flow, and then, live please. And now we cross the lesion. So again, with TCAR, you cross the lesion with protection. Better the wire, please. And I try not to get my wire all the way too much to the top, keep it as limited. And now we're going to cross the lesion with this enflate balloon with an E. That's what Dr. Sumera told me to say, it's with an E. So the balloon now is crossing this lesion. And you can see, I tend to do this under road mapping, which most vascular, okay, go ahead. So now before you start ballooning, we inform the anesthesiologist, patient is prepped, go ahead, balloon. We balloon, and we watch for any kind of bradycardia, blood pressure, hypotension, pick it up, and then we take it down.
So Venky's got this set up very nicely. I mean, he's got the right angle on the bifurcation. You want the wire, you don't want the wire off the top of the field, and that's what you're always watching, to see the wire sneaking up, going inside the head. So he's got it positioned just how you want it. So pre-dilation, Venky?
Yes, and I think, the beauty of this is you're so protected. I tend to pre-dilate these lesions, and I tend to be very aggressive in pre-dilatation rather than post-stent dilatation. The cheese grating effect and everything. So if I have to balloon this twice in a very resistant lesion, I would balloon it and be aggressive with pre-dilatation. And then, of course...
So let me make a point about...
We do an angiogram. Yeah.
But one of the observations from TCD is that here the stenosis is truly in the internal. It's up above where the external is feeding retrograde. If it's a common carotid stenosis and the external is large and it's really up above the stenosis, sometimes you don't get flow reversal. And so that's one of the reasons that TCD's kind of helped parse out where occasionally you just don't get flow reversal established because there's so much retrograde flow coming down the external, it kind of overpowers.
So I tend to pre-dilate and shoot an angiogram before I routinely place my stent because, you could have created a dissection, some sort of other problems that could extend either to the top. But just with balloon dilatation, that luminal gain looks really good. And so we've selected, based on predetermination, based on angiogram, I tend to use longer stents than acute and try to be too cute. So this is an 8 millimeter by 40 millimeter en route carotid stent. We go right up to that lesion because remember, it's not very focal, it's also diffuse disease like the SFA. So make sure you cover as much as you can in this lesion. And yes, I'm not a big fan of very short stents because sometimes you may miss the lesion both at the top and the bottom, and that is really embarrassing. So
Venky, you have two
stents. So generally, if you look at the data on TCAR, 8x40 stent, yeah.
So Venky, you have two screens in front of you, one with the overlay and one that's just live fluoro, huh?
Yes.
Yeah, so that doesn't come across. And that's really important because you can't see anything when you're looking at an overlay like this.
Put one camera on the screen. Chris, just put one camera on the screen, on the major screen if you can. Yeah. Yeah, this is very important. And I do all my AAAs, everything I do, sometimes even legs with road mapping guidance, take a little puff. And you can literally see your road map and go from there, because it gives you so much of convenience, to do it under road mapping. See, you can see 2 screens over there at the bottom.
Yeah,
so
we can barely see.
And one is
Can
my
you
actual.
can you fade down the mask?
Yeah,
there you go. Better.
Yeah. So even when I'm putting in AAA endographs, on one side, you can actually see the markers really well, because sometimes with road mapping and the angiographic dye, the markers move, and then when you move, the markers are not very well visualized. But on the other screen, you can see all of those markers, and I think you should do all of this under road mapping guidance at all. And that's the beauty of these imaging systems, of course, and you've got to make full use of these. I proctor a fair amount of TCARs like you do, Alan and Cassie, and I see some of these, of course, are done under a C-arm, but they don't utilize this road mapping guidance, and they sometimes struggle to cross the lesions too, okay? There you go. I tend to take 2 views. Can you go a little more LAO, maybe? Good. Just a little. And so we are still trying out the egg. Okay, that's good. That's the egg medical system coming into play for radiation protection, like we talked about yesterday. Patient looks good. The cerebral sats are good. Blood pressure, heart rate is really good. Okay, ready? Yep. I think we're done. I don't think we should do anything more. We've sort of treated that lesion that was a very ulcerative lesion in a symptomatic patient. And I think these patients do. I've done, I don't know, the numbers, but
all right. So let me ask you a question, Venki, of the panel. No cerebral angiogram, or did you do a cerebral angiogram?
That's what I was going to ask you.
I used to in the
you're going to do a
beginning.
cerebral angiogram?
Yeah.
So again, one of the advantages of
I used to do that,
TCD.
and we used to do that routinely.
Yeah.
We used to do that routinely pre and post when we did transfemoral carotid stenting, and then I started in my first few cases to do this pre and post. But a lot of times, the CT is of the neck, so we don't have pre. And so now I tend not to, unless I have some degree of dissection or a flap or a low fill. But for you, I can do one. Go to the head, we'll do one. Go up the cerebral, go one anterior, one lateral.
So again, another argument that I forgot to make for
but maybe not the
TCD
right thing.
is we're monitoring the
Yes.
middle cerebral artery. And unless there's a major change, which almost never happens, we just basically use that as our
Yes.
completion study and move along.
Higher.
Can I just ask,
To the brain, to the brain, yeah.
Venki, so
Take
for,
one
Alan was talking
Yeah.
about when we look at we treat our foot better than the brain, when we do the after intervention, any stenting, angioplasty, we always do a look at the foot, make sure there's no emboli. So you say you're not routine do cerebral angio anymore?
Yeah, I tend not to. I don't know, I've sort of, and there has been no difference at all. And also, I don't use too much dye in this, and I aspirate all the dye off too, and I don't inject hard. See, the thing with reversal of flow, when you're shooting, you stop the reversal of flow. And so if you shoot too hard, you can actually overcome that reversal of flow, and you can actually embolize even with multiple injections. I tend to take very minimal pictures, and I tend not to inject too hard, and then let the flow reversal do its work as soon as the injection is completed. So you can see that the stent is deployed pretty well. We sometimes tend to get that little step at the distal end, but I've noticed that they generally resolve and they get really good. And so I think I'll let the flow reversal run. Can you come back to the LAO position, original position? I will take another AP view if you want for cerebral circulation, but I know it looks really good. And then we let the flow reversal run for another minute or two, and then undo the clamping of the carotid, and then basically you're done. Yeah. The procedure does not take more than 30, 35 minutes,
All right, so since my job is to sell TCD, let me say how we'd use it. Is you monitor the middle cerebral artery, ipsilateral middle cerebral artery, you clamp the carotid, it always drops. If it doesn't drop, you're monitoring the wrong artery, yes. And you're on the posterior communicator, but it usually comes back up. The TCD guy communicates with the anesthesiologist and adjusts your blood pressure. If it's low, you bring the blood pressure up, and the MCA velocity will go up. Once you're on flow reversal, if you do the injection and you time it right, you should not see it inside the head. And so it helps us improve the timing of flow reversal, because he's looking at the MCA, that should be above the level where your dye is hitting. Once you put the stent in and you come off, then you look for hyperperfusion. And again, these really high-grade stenosis, the definition of hyperperfusion by TCD is greater than 150% baseline. Then that kicks in a blood pressure modification protocol. Typically, your brain auto-regulation does not work for the first few minutes. But after about 15, 20 minutes of increased flow going up there, it starts accommodating. You can see all this happen in real time.
Okay.
And if need be, you can actually move the patient to the ICU and keep it going until the auto-regulation kicks back in. Yeah, Cassie.
So I'm glad with I'm happy with what we have here. You'll discuss the the points that we need to make for this particular session, including the runway, which should be at least 5 centimeters. If it is shorter, what do you do? If you have a patient with a bull neck and you go percutaneous, different ways of overcoming the so-called limitations of the TCAR procedure. Obviously, you can do carotid endot. It's still the gold standard, in my opinion. And then further on, you can further discuss what is new on the horizon in terms of how transfemoral is going to come about, and then finally, any new technology in the flow reversal with other new technology on the horizon. So thank you, guys. I think that'll give you a good discussion. I'm going to get this patient out of here and get the next case for the next session.
Cassie's got one comment.
Alan. Thanks for a good
he
moderation.
wants to Go ahead, Cassie.
I have one comment just on the medical management. Just to begin, Venki, you always make difficult cases look very simple. On the CAT scan, the common carotid looked quite deep, and sometimes those dissections can be difficult. Now, I have a comment on the the importance of dual antiplatelet therapy. Now, there's more studies on TCARs have always shown the duration and the effectiveness of dual antiplatelet therapy is very important. Venki mentioned Verify Now. Now, Verify Now is a platelet function test, so it looks to see whether your platelets are sticky or not sticky.
Yes.
If you give a bolus dose of Plavix, which is 300 milligrams, and patient gets a Verify Now, most of the times it will show that you have effective antiplatelet management. Now, once the patients go home, they go home on 75 milligrams of Plavix. There's a group of people called intermediate metabolizers. So the Plavix gets converted by the liver to its active metabolite. If you're an intermediate metabolizer, that's 30% of the population, 75 milligrams Plavix will not work. So if you're going to use Plavix, and you're given a bolus dose, don't depend just on Verify Now. You do have to get a 2C19 test. It is fully reimbursed by Medicare. So it's very important if you're giving Plavix, if you're using just Verify Now, you have to follow it up with a 2C19 if you're given a bolus dose of Plavix. What I simply do is I just stop using Plavix at all. I just use aspirin Efient on all my patients, much more reliable dual antiplatelet therapy. So don't forget the importance of medical management. They all need to be on statins, dual antiplatelet therapy. That will certainly decrease your complication rates and long-term follow-up outcomes.
All right, let's move along.
Great, Cassie. Very good point. Very good point. Yeah. And so, we've had certain Plavix-resistant patients who actually had, I said like a TIA. And then, of course, I think the protocol mandates that you use anti-cholesterol medications, dual antiplatelet therapy. We probably stop the Plavix after 30 days, or the Brilinta, and then continue the aspirin. So post-op management is good, and we've had excellent results with all of, I personally have done close to 400, like I said, and it's quick, it's fast, and I think if you look at the curves of over the years of our carotid endarterectomies going like this, TCAR is now basically creating, a cross, and I think the TCAR is actually going a little higher than even our carotid endarts. And in this procedure, I think is standing the test of time unless something really new comes about. So thanks, Cassie. Thanks, everyone on the panel. Thanks, Alan. I'll see you guys soon. Thanks. Bye-bye.
So, Wayne, I've got a question for you about credentialing. Can you get credentialed to do transfemoral carotid stenting separate from TCAR? In other words, can you get TCAR privileges without having transfemoral carotid stenting privileges?
I think there's include different skill level, right? TCAR requires someone knows carotid surgical anatomy. The stenting part, cross lesion, put a wire across, those are very similar between the two. But TCAR require you understand where the nerve is, where the vessel is, where the muscle is. So that's different from transfemoral carotid stenting. Transfemoral carotid stenting, you really know how to navigate it, aortic arch, and different catheter wires. Yeah,
the problem with that is you may find half the vascular surgery community defaults out of being able to do transfemoral carotid stenting if all we do is do TCAR. That's my concern about it. All right, we should probably move along.